Hello again. Today I want to talk about ketamine. We trained on this last week, and this video is meant to summarize the things that we talked about last week. So my whiteboard is a little bit busy today, but stay with me. I think this is my best take on using ketamine and what that looks like. All right, so I'm going to take this sort of piece at a time. And before we start, I want to make sure we're very clear on what we're talking about when it comes to using ketamine. There's two ways to use ketamine. And this can be in the ER, but more likely in EMS. And how do we use it? One, we can use it at pain dosing, which is like low-end ketamine dosing, and we can use that much bigger dosing for dissociation dosing, right? And so before we get to that, I want to mention this down here. So, and this is credit to one of my EMS chiefs, one of my fire chiefs who mentioned these two topics, or these two categories of people here. So we have the can't stop folks and the won't stop folks. All right, so let's talk about the won't stop folks. I think this is worth mentioning because when you talk with the lay public about somebody who's out of control or agitated, right? Most people probably have had experience where they had an intoxicated uncle at a wedding. They were able to talk him into his taxi and get him to his hotel, or they walked him upstairs to they're in the ballroom of the hotel and they were able to get him to his room and put him to bed. And Uncle Bob was agitated and kind of taking a swing at people, and he was 10 foot tall and bulletproof, and he was agitated, and they were able to talk him down, right? So that is a category of patient, but that's not the category of patient that we're talking about that needs ketamine. When we encounter those people on scene, ideally we would use verbal de-escalation. That's our go-to. Across the board, we wish everybody could be verbally de-escalated. If you look at the Beta Project from some years ago, which is essentially emergency medicine psychiatrists, psychologists, people who care the most about people who are mentally ill with chemical dependency issues, they, even in that paper and talking about best practices, they acknowledge that there are a category of patients who cannot be verbally de-escalated. Right, so that's who we're going to talk about in a second, the can't stop folks. But the won't stop, obviously they are still cognitively with it enough that hopefully verbal de-escalation works. You could still maybe reason with them like, hey Bob, you just need to go to bed, you're getting a little out of control, start swinging at people, like, right, calm down, right? Maybe they also need some medicine like droperidol or Zyprexa, an Ativan or risperidone. There are oral options for that. There are IV, IM options. Maybe typically we don't get IVs in people who are completely out of control. But maybe you had an IV, but now the patient is ramping up for whatever reason. You can give those IV, right? So that's the won't stop category. But ideally, they still have some cognitive awareness enough to know they should stop whatever behavior they're doing, right? That's very different than the can't stop category. Patients who are in the can't stop category are delirious. They have delirium. They are not cognitively aware of what's going on. You can't reason with them. You can't have a conversation explaining, you're metabolically getting much sicker as we have this conversation because you're fighting with everyone. That's why you're so sweaty. That's why you're breathing fast. That's why your heart rate's through the roof and your blood pressure's through the roof. Sir, if we don't get you to medical care, you're going to get much, much sicker metabolically. Your adrenaline is spiking right now. Your lactic acid is getting worse. Your pH is dropping, right? We're not having a conversation with these people. They are not cognitively aware of what's going on. They can't discuss any risks and benefits with you. They are not able to stop, right? It's like doing a HIIT workout, like a high intensity interval training. It's like doing a HIIT workout without a governor. Lactic acid essentially is one of the pieces that causes a governor. In a normal person who's functioning, when you do a HIIT workout, you don't keep going because you have a governor system that's in place like, you need to slow down. You're getting short of breath, your lactic acid is climbing, your pH is dropping, right? You have a governor. These patients essentially don't have a governor. They are not cognitively aware. They don't have the feedback mechanism in place to know that, this is getting dangerous. You are seriously dropping your pH way lower than it should be, and you're not going to be able to recover from this, right? So those are the folks that need ketamine, and that's what we're talking about today, right? Again, it's a very low frequency, high risk event. I would argue that when ketamine is the answer, it's the only answer. And to be clear about that, that doesn't mean that ketamine is always the answer. That's not nearly the case, right? But the sickest patients, and there's data that supports this out of Hennepin, that the sickest patients get under control the fastest. And by under control, I mean we stop their metabolic worsening, right? Again, their lactate's climbing, their pH is dropping, their adrenaline is through the roof. They are getting closer and closer to having a cardiac arrest because of that whole metabolic milieu that's going on. So the patients that are the sickest on that continuum need ketamine to get them under control the fastest, to get them to a higher level of care, and to stop that fight and stop that metabolic process from getting worse, right? So that's the patient that we're talking about today. So they are in the can't stop category. They are not cognitively aware of what's going on. They are too delirious to have a conversation about this. They are sick, and they most need to get to medical care the soonest. So, all right, so let's talk about it. Bring your eyes up to this upper left corner of the graph here. So on the y-axis, we have ketamine effect from analgesia up to dissociation. And then on the bottom, we have your ketamine dose. So again, it's not drawn to scale here, but on the lower end, we have about 25 milligrams. And this can be 10, 20, maybe 30, depending on the size of the patient. This is somebody, maybe a traumatic patient who has hypotension you don't want to use opioids for, but you want to give them ketamine to help get their pain under control. Right? Maybe the old lady with a hip fracture, something like that. So we want to stay in the lower end of the dosing with ketamine. 25 I just use as an example. It's not an exact number, but generally speaking, low, like 10, 20, 30. Once you start getting higher than that, you get into this range here, which we'll talk about in a second. I personally remember taking care of a lady who had acute and chronic back pain in the ER. Opioids wasn't working. Pretty much everything we were doing wasn't working. We gave her 10 milligrams of ketamine, and she didn't lose it, but she was very much not happy with us. Like, don't ever give me that again. That feels terrible, right? So even at low dose, there are patients that somehow get into this sort of like bad dosing of ketamine. And this is like your recreational dosing of ketamine between here and here, right? This is like the K-hole. If you're using ketamine recreationally, you're probably somewhere in here. And something that's worth mentioning here is that when you use drugs, generally speaking, you want to be in a happy place when you're using drugs. If you're going to smoke marijuana, you want to sit on your couch and have some munchies available, right? Like you're in a peaceful place. You expect that trip to probably go okay in theory, right? Patients who are completely out of control, agitated, whatever got them there, whether it's mental illness, whether it was chemical dependency, whether it's a combination of those things, whatever got them into this state, they're not in a good place to be having a trip, right? You don't want to put them in the K-hole or making them have some sort of, this is not going to be a euphoric experience when they're in here, right? You want them to get dissociated, right? They need to be, essentially take them out of the equation so we can take care of them. They're impeding their own care when they're having a bad trip or when they're fighting here. So again, your ketamine dosing, stay on the low end, right, for pain. But if they need to be dissociated, go big. And I use 500 because that's a common dosing. The bottles come in 500, they come in 1,000, right? So you want them dissociated. An interesting thing about ketamine is that once you get them dissociated, right, this arrow doesn't keep going up, right? You're dissociated. That's where this levels off. Once you're dissociated, you're dissociated. There's not something called more dissociated. It's like a ceiling on this. In theory, then, your cardiovascular effects and respiratory effects don't get worse, right? We know that happens with opioids. If you give enough opioids, somebody stops breathing. That's the way that works. There's a dose-dependent response to giving opioids. With ketamine, there's not. It doesn't work the same way. Are there exceptions to the rule? Yes. With ketamine, with droperidol, with Zyprexa, with all of them, there are exceptions to the rule, and you should be prepared for some respiratory depression with all of those medications. None of them are 100% not going to cause any respiratory depression. But the point and the benefit of ketamine is that, generally speaking, once you get to this dissociated point, that your brain is sort of out of the equation, your respiratory effects and your cardiovascular effects do not get worse. Again, very different than an opioid. If I gave somebody enough fentanyl, I might make them, they're not going to be dissociated, they're going to be out of it. And if I keep giving enough fentanyl, they're going to stop breathing and die, right? Like it's a very predictable thing. If you give enough. Ketamine does not work that way. What does happen if you give too much ketamine is sort of exemplified by this up here. So we have on the, essentially this blue line is like time. So now we have ketamine dosing and time tracking along together. If I give ketamine here, say I give 500, they're going to say dissociate it for a while, and then they'll start to come out of it, right? If I give 1,000 of ketamine, this is going to be longer. This curve stretches out longer, and then it falls off, right? And this is borne out by the literature because when you look at the literature for case reports of overdosing of ketamine, again, patients don't get deeper, they don't get more dissociated, but they stay down longer. That's what happened. I know there's one many years ago I looked at that kiddo that got way overdosed on ketamine in the ER for a sedation, and they were down for longer. They didn't get sicker, they didn't die, right? But they just stayed down for longer. So the more you give, the longer patients stay down when you give ketamine, right? You don't get worse this way. You don't get more dissociated. You stay down longer, right? So there's little downside to staying down longer in that regard. So, all right. So I'm going to change this just so we can move to this other graph here. So, all right. So I hope that makes sense in terms of the dosing of ketamine. The next graph now, draw your attention to the upper right corner here. So again, this is kind of busy, but we'll talk through the parts of this. On the bottom axis, the x-axis, we have time. On the y-axis, we have essentially your sympathetic and parasympathetic response. This is like your arousal curve. This could be referred to an arousal curve. It's your attentiveness, your performance, your learning actually falls in the same category, right? So all these things. But when we show up on scene with a patient, Let's start with law enforcement. They're represented as blue on the graph, right? So law enforcement is on scene with somebody. They've been called to the scene, and let's go with a textbook. This is 20 degrees in a Minnesota winter. This patient is naked. They have a machete. They are wrecking lights. They are punching lights. They have some cuts to themselves. They're covered in blood, sweating profusely, completely out of control, right? Like this textbook, we're all clear. We've all seen it. Anybody who's been in the ER EMS has seen this and knows this patient is completely out of control. They're well past the point of verbal de-escalation. Drew parallel is not going to help. There's no reasoning with them. They are not cognitively aware of what's going on. Law enforcement recognizes this. They've seen these patients before. They know very quickly when they get on scene that the call was for maybe criminal activity because somebody smashed somebody called because this guy was smashing headlights in an apartment building parking lot, right? Cops get on scene and see, oh, this guy's naked with a machete. He's covered in blood. He's smashing all the lights on every car in the parking lot. This is not a crime. This is something else is going on. This is a medical problem, right? And we'll talk about, again, the communication here in terms of calling EMS later. But everybody's aware that this is a problem. They need to get this person under control, and they need to get EMS there, right? So once this fight is on, and they have to corral this patient, and let's say there's bystanders there. They can't just ignore this guy. They can't just let him smash all these cars. There's bystanders around. Maybe it's a party, a New Year's Eve party, right? There's people around. This guy is a danger to himself, first and foremost, and he's a danger to everybody around him. The cops know this, so they're already in sympathetic, right? And they're going to be on high alert, right? EMS, on the other hand, is still in parasympathetic. They get called from the station, wherever they're responding from, very quickly on scene. They're going to get into sympathetic real quick because they're on scene and realize what's going on, right? And as a hint of this, how fast they get here, there's probably CAD notes coming through, like this, exactly what he's doing. Dispatch reporting, a guy is smashing, he's naked with a machete, covered in blood, 20 degrees outside, smashing cars, right? Okay, so EMS is very quickly aware of what's going on, right? So let's say they get there, everybody's on the same page. This guy's out of control. He needs ketamine. He needs to get to a hospital. He is cognitively not aware of what's going on. We can't verbally de-escalate, and we get there very quickly. Like, we make these decisions like, we've seen this before. Based on our education and our training and our experience, we know this guy's out of control. He needs ketamine for his own safety and for the safety of everybody on scene. All right, so we give him ketamine. What's the natural inclination for the cops on scene? What's going to happen to them? Once they hand this off to EMS and EMS gets there and gives ketamine, very quickly the cops are going to dump into parasympathetic. And this is not a ding on any cops that do this. This is human nature. If you go back and read literature on war, you'll find that there's a quote, something to the effect like the moment of greatest vulnerability is immediately after a victory, right? Like, you just succeeded. It's like, big breath. We're done. The problem's solved. We won, right? That's what cops are doing, because at this point, this is a handoff. Like, this was a cop problem that they very quickly realized was not actually a cop problem, but they're still in it. They're still in the fight trying to get this guy under control. And now once EMS gives ketamine, we can take a break. This guy starts to come down. We peel off of this pile that we're on. We hand him over to ketamine. We're back into parasympathetic, right? What is a tendency for EMS to do? Right? And this doesn't make EMS bad people either. This is just the human body and the response to this. You've just been in a fight and you're involved in this whole thing. Your tendency is to do this, right? You're over here tracking, you're like, oh, big breath, we're good, right? No, wrong. This is absolutely the wrong thing. You cannot get sucked into the parasympathetic backlash that police are in, right? They sort of peel off, they hand it off to you. You can't get sucked into this. In fact, your drive needs to continue up. You need to be on heightened alert at this point. And again, maybe it doesn't go straight up like this. You want this to level off. We don't want to get out of control, because if we're too, there's a curve there that is beyond the discussion today. But you want to be on heightened alert and stay alert throughout all of this, depending on how far that goes, right? So don't get sucked in. If you're EMS giving ketamine, you can't get out of control. You can't fall into the parasympathetic backlash that cops fall into. You have to stay on high alert, and maybe even higher alert than where you were when you got here, right? So let's talk about another piece of this then. This green up here is monitoring, right? And there's discussion about what monitoring has to happen before you give patients ketamine. And I'm going to argue that we need to do these things, absolutely. We need to do SpO2, blood pressure, my typo there, blood pressure, heart rate, end tidal CO2. Those things need to happen. None of those things are therapeutic. If this patient is metabolically sick, and we determined that already, and we'll get to how we determine that, these things are not therapeutic. These don't help the patient. They help your monitoring. They don't help the patient. The ketamine is what was therapeutic to the patient, to get that patient under control, to get them down the road, right? But that's not to say that we're not doing any monitoring before we give the ketamine, right? So this is what matters. And when you get into ketamine dosing, there's a big push on giving too much ketamine, which gets back to this graph, which I think is not a big a deal. I think the thing that keeps the patient most of all safe and us safe is the fact that we're paying attention to what we're doing. So let's back this up again. Now let's look at monitoring versus time. Take this curve out of it and that discussion, but now we're monitoring over time, right? So before we even get there, we had CAD notes. We had naked guy in a Minnesota winter smashing everything, covered in blood, and has a machete, right? You already have some heightened alert that this guy is out of control, probably not a criminal activity, because that's not a typical criminal pattern to take a machete and get naked and go smash cars, right? That's not a typical crime. That's a metabolic problem because it's not coherent with anything else that's going on. Right? When you get on scene immediately, and let's say now cops have subdued this guy, they've got him corralled, they've piled on, there's 6 cops holding this guy down, waiting for you to get there to help, right? Visually, you can see what's going on. What else can you see visually, right? You can see this guy is awfully sweaty. We're all wearing coats. This guy is really sweaty and it's 20 degrees outside and he's naked. Okay, so visually you're seeing that. What else can you see visually? You can see his respiratory rate. Like, that dude is breathing fast. Again, you've all seen patients who are septic or in DKA or super acidotic and they're breathing really fast because they're breathing off their CO2 because they're acidotic. This person is the same metabolic condition and probably worse, right? They're breathing off their CO2, they're breathing really fast. So you already have, when you're on scene, whatever you're seeing of this patient, whatever you can see in this pile, you can see they're breathing really fast, they're really sweaty, right? Tactile. Let's look at that one. So let's say you got an arm, right? This person is being held down by cops, waiting for you to help. You get your hand in there and you feel a pulse. You got a wrist. Maybe you don't have much else because this guy is still fighting and throwing cops. You have a wrist. What do you have there? Again, you have skin sensation. So already you're like, yep, they are really sweaty. Everybody else is cold. This dude's really sweaty. That's a problem. What else do you have when you feel a pulse? You've all felt weak and thready. When you show up on a bad trauma, somebody who just got run over by a car who was shot, and you don't have anything else, and you show up on scene, you grab a pulse, like, ooh, that's really fast and really weak. This guy is not fast and weak. He's going to be fast and bounding, right? So, and I don't need a number. I don't need you to say like, well, give me a minute, guys. I'm gonna check a pulse for like a minute. Shh. I'm trying to feel a pulse here, right? It's ridiculous. You're like, whoa, that's fast and it's really strong. So I have a bounding tachycardic pulse. I know this guy's hypertensive, tachycardic. So now I know he's breathing fast, he's sweaty, he's tachycardic and hypertensive, right? That's just a very quick assessment with all you got. Audibly, what do you have? You can hear it grunting, you can hear yelling, screaming, you can hear his breathing. That guy's just panting. Again, he's in the middle of a HIIT workout and he doesn't know he should stop, right? So you have all that. That's part of your monitoring, right? That's all you need. And at that point, maybe you make a guess about weight. I don't think weight here is one that gets discussed. Like, we need to have some perfectly accurate prediction of weight. I don't think that's the biggest deal. That's not my biggest concern. Going back to this part about we want them dissociated. If they would get dissociated at maybe 400 milligrams, fine. If we give 5, do I care? Not really, because I don't think this is the biggest part of the assessment that matters. I think these things are way more important, and then we're going to get onto those things, right? So all of that happens. We give the ketamine. Again, cops are going to peel off. They're in parasympathetic. They're going to slowly peel off. You are going to stay in, EMS is going to stay in heightened alert. And now, as this proceeds, we're going to get a pulse ox on there. We're going to get the 4-lead cardiac monitor on there. We're going to get a blood pressure cuff on. We're going to get end-tidal CO2 on there. All those things are going to happen, and the monitoring increases essentially. Obviously, it doesn't peak. It's going to level off at some point. We can't just indefinitely add more monitoring, but you get the point. Like, at some point, we add those things to the monitoring piece of this as we continue down the road to the ER. Right? Also, we don't want to stay on scene when we do this. Once we give this, and as soon as we're able, we're going to add the monitoring pieces, and we're going to get in the ambulance and get down the road. Because what do they need? Besides monitoring, they need treatments. They need IV fluid. A couple of IVs is not a bad idea. Giving bicarb is not a bad idea. There's very little downside to giving bicarb. We could get into the weeds about when you give bicarb, like a patient with DKA. Usually, often a pH of 7 is often used. Maybe all these patients are not that low, but besides an infiltrated IV, there's little downside to giving some bicarb. And then you're going to drive. Again, you need to get down the road and get to the ER where this patient can receive a higher level of care, right? So that's that piece of it. The next thing I talk about is what is this whole giving ketamine? What do we call that? Why are we giving ketamine? What's the point of that? And I would say it's this. It's a necessary, unplanned procedural sedation. All right, so let's talk about the pieces of this and why I think it's the way to describe it. Right? It's necessary. Again, EMS, law enforcement, they were called to scene by something. Somebody who's getting their car smashed. Hey, dude, there's a naked dude smashing my car in the parking lot with a machete and he's covered in blood. Right? We got called there. We can't walk away from this. It's not like the cops or you guys or EMS shows up and like, well, that's a pretty big problem. Good luck with that. I hope somebody solves that problem, right? We are there. We were called. Somebody called 911. It's necessary. We have to deal with this problem, right? And I don't mean to call the patient a problem. We have to deal with this scenario that's going on for the good of the patient, right? And we already talked about, again, this is a patient. Cops very quickly know this is not a crime, right? This is a patient, right? So they make that distinction very early, and they're aware of that because they've seen this before. Because of their training and experience, they know what this looks like, which will come back to our communication piece in a minute, right? It's unplanned. So ketamine has long been used in the ER for pediatric sedation. I had to do one last month. I had a 14-month-old girl who smashed her nose on the hearth of a fireplace, right? Very hard to sew up a 14-month-old girl on her nose without some sedation. It's pretty difficult to distract her and put some numbing medicine in her nose and then put some sutures in her nose when she's looking at me like that, right? There's no way this is going to work, right? So what do? We give her ketamine, right? So this is all planned though. So in the ER, I have time. I can have dad sign the consent. I can talk about all the ins and outs of how this is going to go. Say, okay, we're going to give her a shot of ketamine. We don't need to make her upset before that. So I don't need to put the 4-lead cardiac monitor in the end-tidal CO2, in the oxygen, all of that on her first. We'll give her ketamine. She cries about the shot, just like she's getting a shot when she's in clinic to get her whatever vaccine. And then she starts to go to sleep. As she starts to get nystagmus and go down, then all of my resources, and I have techs and I have nurses and respiratory therapy to help me, we all descend upon her. We put the cardiac monitor on her. We put the end-tidal CO2. We put some oxygen on her. We have the suction ready. She's on the monitor. We have all of our airway equipment ready. Right? This is a planned procedural sedation. That's typical in the ER. That's not what we have here. Right? You had from the time the CAD notes came out here to the fact that you gave ketamine to make that decision that this is what needs to happen. And you need to get if that's the decision that needs to be made, you need to get there very quickly. So we can pretty much say this is not a planned procedural sedation. This was not planned. It was unplanned, right? But we still get to the same endpoint. So we give ketamine, then we do all of our monitoring, right? It's just that you're behind the curve because you don't get to plan this all out. This is not where you get on scene with a patient who's out of control and then you say, hey, sir, could we just get the ambulance for us? We have our suction set up in there. We have our monitor. We're going to put the blood pressure cuff on you. Could you put this pulse ox on your finger? Right? Like even me saying it, it sounds ridiculous because people that have done this know this is a disaster, right? So we have necessary, unplanned, and then I'm going to call it procedural sedation, right? So let's talk about the procedure piece. Like what procedure? Like in the girl in the ER, like we're sewing up her nose. We use ketamine for a shoulder dislocation. Use it for an abscess, IND, like other things on kids, right? Using it as adults as well, but a chest tube in adults, maybe a hypotensive trauma patient who's kind of with it, but kind of hypotensive, needs a chest tube and we need some sedation, you could use ketamine, right? Like there's ways that we use it in the ER, right? What's the procedure that's happening here? Why do I feel okay using that word, right? The procedure is getting this guy from the sidewalk in front of the apartment building where he smashed all the cars with his machete and is covered in blood and naked and cold in the Minnesota winter. He needs to get to the ER. The procedure is the transport, essentially, right? Him from on the ground after the fight with the cops and the firefighters that are on scene that are helping you. He needs to get on the gurney. He needs to get down the road to the ambulance, or in the ambulance down the road to the ER. So that's the procedure, right? His safe transport where he's not getting metabolically worse, not getting more acidotic. His pH is not getting worse. He's not getting imminently closer to having a cardiac arrest because of the metabolic derangement. He needs to get to the ER. So that's the procedure. We're using a ketamine sedation to facilitate that procedure, right? So again, put it all together. We're here on scene. We have to do something with this. It's not a crime. We have to do something medically with this guy. It's necessary. It's not planned. We didn't pick this. We didn't generate the 911 call. Somebody else did, and we didn't have much time for it. We didn't have time to set up everything that we normally would in the ER for a kid who needs a nose laceration repaired, right? But the procedure then is getting down the road safely while the patient's not getting worse. And we're going to use ketamine sedation to facilitate that, all right? Because it's the best option for patients who are completely out of control and not cognitively aware of the fact that they are getting more metabolically sick. So that's what I call it. One last point before we wrap up, right? Communication is critical here. And there's been, in some states, there's some legislation that limits communication between law enforcement and EMS regarding this topic and specific wording that's used. I was at a conference in the last couple of months. The International Association of Chiefs of Police has a police physician section. In their essentially their white paper, their statement would argue that law enforcement and EMS need to have better communication on scene, and I would echo that. I think taking away communication from these entities of public safety is a disaster, right? And it's hard to make a case that less communication between all these three people on scene, whatever scene they're on, whether it was a fire that now it turned into, like, you know, cops show up, there's a fire's on scene, and it was a rescue, there's a domestic, like whatever the thing is that all three of these entities end up on scene, more communication is better, almost without fail. Nobody's ever been to an after-action report on either a simulated or a real event where it's like, well, communication was perfect. Everybody knew exactly what they needed to know every time. It was ideal, right? Nobody's ever been to one of those, right? Communication is critical for these folks in real life on scene. The other point I'll make in closing is that, let's say cops show up on scene and there's a house fire, right? The call was for whatever, smoke showing, they got there first, like, oh, well, better call the firefighters, they better bring some water, right? The cops know that even though fire is not really in their lane per se, they know that water is the right tool for the job, right? Let's say that EMS shows up on scene because the call was for fall and sprained ankle, right? And they get there, as they pull up to the house, they hear arguing, like, this sounds like a domestic, and then they hear gunshots from the house, right? So this fall, sprained ankle was because of a domestic that the caller didn't tell 911 on the front end, but now EMS gets there and there's gunshots, right? That's out of their lane. EMS knows very well that if there's gunshots on scene, that's not their problem, at least not immediately. Law enforcement needs to show up with guns and solve that problem, and then EMS moves in, right? So again, gunshots are out of EMS's lane, but nobody has a problem if EMS was like, hey, bring the cops with the guns, there's a problem here, right? You can make that argument for any of these, right? One of these shows up on scene, and the problem is not really theirs. They have enough experience and training to say, this is a problem that belongs in somebody else's lane, and I know the tool for the job. It's not my lane per se, but I know the right tool for the job. I would make the case that ketamine falls in the same category. So when cops show up on scene, this guy that we've talked about, completely out of control, very clearly textbook, this patient is metabolically ill and needs ketamine. So when they call EMS and say, hey, bring the ketamine, we are very worried about this guy, right? I don't have any problem with that. In the same way they would call the firefighters for water for a house fire, right? They have enough experience and training to know this thing is a problem, and I know what the right tool for the job is. That doesn't mean that they're directing EMS to give ketamine, right? Just like they're not telling the firefighters, hey, plug into that hydrant over there, hook up your pumper truck here, get your ladder truck over here, right? They're not doing that, right? But they still know what solves the problem, right? So I don't have any problem with the communication. I think there needs to be more communication between those three entities on scene, regardless of the situation, whether it's this one that we're talking about today or any other time. Communication on scene is crucial. And one last point I'll make that I just thought of, when it gets to this monitoring thing, again, people get bent out of shape about the weight being the most important thing. I don't think that's it. Again, I think the other assessments that we do and the monitoring that we do matter more. The other piece of this that's important is, let's say there's two medics that show up. It's a gaggle of cops and firefighters on scene. Two medics show up. They should be talking about this out loud, right? And the reason for that is twofold. One, the first one is that it's good for the patient, right? You want your partner on scene to see what you're seeing. If you're the one, say your partner's, whatever, back from the scene, you're the one that's actually doing direct patient care. You're like, holy smokes, this guy's breathing really fast. That heart rate is fast. He's hypertensive. He's tachycardic. He's breathing really fast. He's super sweaty, right? Say all of that out loud, right? For the good of the patient and the good of everybody on scene that knows where you're going with this. Maybe there's inexperienced either firefighters on scene or cops on scene that are not clear. They haven't seen this as much. They're newer on the job. They're not entirely clear what's going on, right? There's a new cop on scene. It's like, oh, we got to still arrest this guy. He hasn't made the switch to the fact that, oh, arrest is not in this guy's future. The ER is in this guy's future, right? So get everybody on the same page by talking about that so they know where you're going. Like, hey, man, so when you're the EMS provider assessing the patient initially in this stage, your partners are on scene knowing what's going on. You're telling the cops, hey, this guy's super sweaty. I'm really worried about this guy metabolically, right? It gets everybody on the same page to know where this is going. Like, hey, we're going to give ketamine. I need you to hold that arm, that leg, Don't let him kick anybody. We need to get under this coat and the snow pants the dude's wearing, right? Again, now I'm changing the scenario a bit, but you need to get to some point where you can inject him with ketamine, right? So get everybody on the same page. The secondary benefit of that is the fact that there's body cameras on. Cops are going to have body cameras. The public is standing around with body cameras. But again, this is documenting the good work you're doing. We're not doing this to play to the camera, right? This is not a fake like, hey, if I say this, it looks like I'm caring. No, you are actually caring. You're taking care of the patient. You're doing the best you can for the patient, and it's going to get captured on body cam or civilian camera, right? So the patient care is the primary issue there. The secondary benefit is that it's going to be on camera somewhere. But again, we want the patient's care to be the primary thing. We want everybody to be on the same page, and we know what direction this call is going. So with that, I'll close. I hope that shed some light on dealing with ketamine. Again, a low frequency, high risk event.